The SDS Task Force on Quality Initiatives is pleased to present the SDS Mediastinal Staging webinar. My name is David Wormuth, and I'm a practicing thoracic surgeon in New York and a member of our task force. Our presenters today include Dr. Michael Lanuti from Boston and Dr. Moishe Liberman from Montreal. I have no disclosures. The National Comprehensive Cancer Network, European Society of Thoracic Surgeons, and American College of Chest Physicians each have guidelines addressing this topic area. The SDS is currently working on one as well. It is important to note that there are apparent differences of opinion regarding lung cancer staging options. This slide shows the data points that are collected in the current version of the SDS General Thoracic Surgery database. As you can see, with the number of options for staging the mediastinum, the feeling of the SDS is that this is a very important topic. Our webinar today will cover the following topics: mediastinoscopy, PET, anterior mediastinotomy, BATS, EBUS, and EUS. The first to present is Dr. Michael Lanuti.
Hi, this is Michael Lanuti. I'm one of the thoracic surgeons at Mass General Hospital and have been tasked by the Society of Thoracic Surgeons to talk to you about modalities for mediastinal staging of lung cancer. I have no disclosures. Staging modalities for lung cancer have evolved over the past 2 decades, where incremental improvements have been made in sensitivity and accuracy as depicted in this slide. CT chest has been the historical workhorse of lung cancer staging, but is still hampered by reduced sensitivity, particularly for nodal metastases. CT PET has enhanced this. Notice that endobronchial ultrasound and mediastinoscopy are in close proximity regarding sensitivity and accuracy. Meta-analysis of each of these staging modalities demonstrates 78 to 90% sensitivity. I'd like to point out that each staging modality is not necessarily mutually exclusive and are complementary, improving our overall accuracy. Endobronchial ultrasound and endoesophageal ultrasound are excellent tools that enhance staging. I also placed tumor genotype on this spectrum, since this concept will ultimately influence how patients are placed into clinical trials, particularly for early stage disease. Diagnostic quality CT and PET are the primary non-invasive modalities for staging lung cancer. Transmission CT obtained from standard CT PET should not be used as the primary diagnostic study for evaluating a potential lung cancer. Although magnetic resonance imaging techniques for lung cancer are improving, there is still a lack of clarity in the air-filled lung and poor spatial resolution, along with rather lengthy acquisition times. Lymph node assessment is improving with MRI and is being further evaluated with injectable contrast agents in studies. This is an older study that examined the accuracy of diagnostic CT in detecting lymph node metastases. Approximately 143 patients with a diagnosis of lung cancer underwent diagnostic CT, mediastinoscopy, and ultimately pulmonary resection. Lymph nodes were measured on CT and correlated with the presence of microscopic disease seen on pathology. Even small lymph nodes, less than 1 centimeter, had a 13% incidence of metastatic disease. The larger the lymph node, the more likely there was concordant metastatic disease. The study concluded that 20% of normal appearing lymph nodes may contain lymph node metastases, thus speaks to the reduced sensitivity of CT. Nonetheless, CT remains the primary diagnostic modality for suspected lung cancer with grade 1B evidence. When you look at meta-analysis of studies investigating CT and PET for mediastinal lymph node metastases, CT sensitivity, which approximates 51%, is only modest, but is improved with PET up to 74%. PET has clearly improved sensitivity compared to CT, but specificity, as you can see at 85%, is still hampered by false positives. We have learned much about PET, including the non-malignant false positives. Some of the limitations are depicted in this slide. Infectious processes such as organized pneumonia, atypical mycobacterial infection, and sarcoidosis will have PET activity. Remember that rounded atelectasis and ALK can also be false positives. Although PET has become extremely helpful, it is limited by the lack of co-registration with anatomic imaging. false positive, particularly in the mediastinum, are influenced by regions that are endemic with granulomatous disease. The ability to identify nodal N1 disease is improving and often guides endobronchial ultrasound modalities. PET has a resolution of 7 to 8 millimeters, which speaks to false negatives. False negative in the mediastinum ranges from 5 to 10% in anatomically normal lymph nodes by virtue of the presence of micrometastases. PET is the recommended modality by the American College of Chest Physicians for routine clinical staging of lung cancer, with few exceptions. Invasive mediastinal staging consists of cervical mediastinoscopy, including extended cervical mediastinoscopy, Chamberlain procedure, and video-assisted thoracoscopic surgery. Dr. Liberman will discuss endoluminal techniques in the latter part of this webinar. All of our staging modalities have limitations of reach, which is depicted in this Mountain-Dressler lymph node map. Each of the stations have been encircled, which depicts the access for each modality. Mediastinoscopy can only reach the anterior subcarinal and paratracheal lymph nodes. Endobronchial ultrasound and endoesophageal ultrasound have additional reach, including those that can be reached by mediastinoscopy and beyond. Dr. Liberman will describe the use of endobronchial ultrasound and endoesophageal ultrasound in reaching even the aortopulmonary window lymph nodes, which have historically been sampled by more invasive techniques, including Chamberlain procedure and thoracoscopy. Mediastinoscopy has been the historical gold standard for mediastinal lymph node staging for lung cancer. The landscape is changing with the widespread use of endobronchial ultrasound. Pooled data demonstrates that 5 to 8% of patients who undergo mediastinoscopy can have a false negative, and this is by virtue of sampling error. For example, lymph nodes are deemed negative on mediastinoscopy but positive after mediastinal lymph node sampling. Of note, the advent of video mediastinoscopy has further reduced complication rates by virtue of magnified visualization, improved teaching, and more extensive sampling. Video mediastinoscopy is depicted here, where you establish the normal pretracheal plane after finger dissection. Remember that the videoscope allows both direct visualization and magnified visualization, which is its clear advantage. It's improved the ability to teach and to see during dissection. The normal pretracheal plane is established, and the scope is used along with a suction dissector to identify your lymph node stations. The first lymph node station identified here is a 4R lymph node, which appears anthracotic. Normal biopsy forceps is used for all these lymph node stations through the scope. It can fit that rather easily. The lymph node map just reinforces the right paratracheal position. When teaching, the video mediastinoscope clearly allows you to see what the resident or fellow is grasping and how much tissue trauma there is. Although this is out of sequence for me, since I do subcarinal lymph node biopsies towards the end of the sequence, this is the subcarinal position where the right and left airways can be seen towards the periphery of the right and left screen. The advantage of the video mediastinoscope in this region is that you can see well, and you have the ability to pass a second instrument through the mediastinoscope to actually help you dissect away tissue and avoid shear forces on vulnerable structures. This is a technique that I teach the residents vigorously to use two instruments. The left low paratracheal space is being dissected to uncover a 4L lymph node. There's some discussion whether you can achieve lymph node dissection of the 10 position, and most of the time I would say on the left almost impossible, on the right on occasion. This is where I tell the residents less is better, given the close proximity of the esophagus and the left recurrent laryngeal nerve. This is another location where two instruments can help better tease off the tissue. The 2L lymph node position has been already looked at and there was nothing there, so we're moving now to a high right paratracheal position in the region of 2R lymph node, which is being dissected free here. So this 2R lymph node is biopsied just like the rest. And this will complete the mediastinoscopy for this particular patient. Mediastinoscopy remains a relatively safe modality for lymph node staging of the mediastinum, as depicted in these three large retrospective studies that have over 2,000 patients apiece. Complications are few, in the range of less than 1%, and there are very few deaths that have been reported. The deaths have been due to bleeding predominantly. The false negative rate of mediastinoscopy can be attributed to the diligence of the surgeon dissecting and sampling the lymph nodes. The reality is that all lymph node stations are not sampled by thoracic surgeons, which should be carefully scrutinized. Ideally, 5 lymph node stations, stations 2R, 4R, level 7, 2L, and 4L, should be at least examined and sampled if possible. This procedure still needs general anesthesia in a hospital setting, was one of its disadvantages. By far the most frequent complications seen with the use of cervical mediastinoscopy are minor, and those include pneumothorax and limited bleeding in the range of about 2.5%. Recurrent lymph node palsy is probably underreported. Death remains rare, and major complications, although less than 1%, still happen. There are few hard contraindications to mediastinoscopy and include the inability to extend the neck by virtue of few cervical vertebrae or severe kyphosis. The relative contraindications to mediastinoscopy include previous mediastinoscopy, a thyroid goiter, or severe calcific vascular disease in the innominate artery, which may contribute to embolic sequelae when pivoting the mediastinoscope against the innominate artery. The newest recommendations from the American College of Chest Physicians Task Force for staging lung cancer were published late last year and reveal some sobering concepts. In patients who harbor suspicious mediastinal lymph nodes, either by size or FDG-avid N2 or N3 lymph nodes, the committee recommends endobronchial ultrasound or endoesophageal ultrasound as the first diagnostic modality, followed by mediastinoscopy if those endoluminal techniques are negative. This is a paradigm shift from the ACCP recommendations in 2007, where mediastinoscopy was the still favored modality. Routine sampling of all mediastinal lymph nodes using endobronchial ultrasound or endoesophageal ultrasound has not necessarily translated throughout North America or the world. Thoracic surgeons should still do and use the modality they are most comfortable with for staging the mediastinum. Staging suspicious aortopulmonary window lymph nodes in the setting of a left upper lobe lung cancer should be explored by invasive means if the mediastinal lymph nodes centrally are negative. The invasive means are Chamberlain and video thoracoscopy. The routine use of endobronchial ultrasound or endoesophageal ultrasound for sampling aortopulmonary lymph nodes should only be done in the hands of champions. I would like to spend just a minute on when to exclude invasive mediastinal lymph node staging. In patients who harbor suspicious T1A or T1B lesions, again we're talking about lesions that are less than 3 centimeters, in the periphery, mediastinal lymph node staging can be excluded in the presence of normal anatomic lymph nodes seen on CAT scan and negative PET in the mediastinum. Central tumors of the same size, that is less than 3 centimeters, do not necessarily fit this criteria, since the chance of mediastinal lymph node metastases are much higher. A word of caution regarding peripheral tumors that are greater than 2 centimeters where you might avoid the use of invasive mediastinal staging. This study looked at 500 patients with resected T1 disease, again less than 3 centimeters, who harbored a diagnosis of non-small cell lung cancer. They excluded ground glass opacities and bronchoalveolar lesions. Most of the tumors were adenocarcinomas. The mean tumor size in patients without lymph node disease was just under 2 centimeters. Patients with tumors greater than 2 centimeters had a near 27% incidence of mediastinal lymph node metastases. My own interpretation of this in the literature is that I use 2 centimeters as a cutoff for employing invasive mediastinal lymph node staging despite a negative PET in the mediastinum. On towards assessing the aortopulmonary window lymph nodes. Supraortic level 6, often associated with a worse prognosis, and subaortic lymph node station level 5. Aortopulmonary window lymph nodes are much more prevalent with left upper lobe lung cancers and can even be seen in as high as 40% of left lower lobe lung cancers. This region is not easily accessible by standard cervical mediastinoscopy. 4 modalities exist to reach this area and include extended cervical mediastinoscopy, anterior mediastinoscopy or Chamberlain procedure, endoesophageal ultrasound, and sometimes endobronchial ultrasound, and ultimately left thoracoscopy. Extended cervical mediastinoscopy is infrequently employed in many institutions and it is not frequently taught. The Chamberlain procedure is employed to sample both level 6 and sometimes level 5 lymph nodes. It has been described as a transverse parasternal incision at the level of the 2nd or 3rd rib with removal of the costochondral cartilage at one of these levels, ligation of the left internal mammary artery, and use of a mediastinoscope for biopsy. I find the removal of cartilage and ligation of the internal mammary lymph nodes not absolutely necessary. The modality is highly specific, but still has a false negative rate of 10%, since targeted lesions can be missed in this limited field of view. Anterior mediastinotomy or Chamberlain procedure can be enlarged to improve visualization. Pitfalls of this procedure are injury to the vascular structures such as the aorta or the pulmonary artery, injury to the phrenic nerve, and a potential chyle leak from disruption of the lymphatics in this region. I have compared all staging modalities for sampling aortopulmonary window lymph nodes and listed the pros and cons for each. General anesthesia is required for all modalities except for perhaps endoesophageal ultrasound. Endoesophageal ultrasound sampling of aortopulmonary lymph nodes requires extreme skill and is not unlike the X Games in the Olympics. This is not something that can be easily translated across all institutions. Extended cervical mediastinoscopy is not available at all medical centers. The least risk of bleeding comes with left thoracoscopy, but requires a hospital stay. Patients who present with aortopulmonary window lymph nodes are a heterogeneous group, and sampling modalities for these patients should be tailored to the particular scenario. Video thoracoscopy has an excellent role in staging lung cancer and is not often employed as much as it should be. It is a modality for sampling aortopulmonary window lymph nodes, which is very safe. The false negative rate is lower than other modalities, but still not zero due to sampling error. Video thoracoscopy is often performed at the time of planned pulmonary resection in the left hemithorax to assess T status and rule out chest wall, T3, or vascular T4 invasion. In summary, integrated PET-CT has revolutionized lung cancer staging, but does not obviate the need for mediastinal lymph node staging except for peripheral T1A or T1B tumors, which are negative in the mediastinum. Mediastinoscopy is still a modality by which all alternative mediastinal sampling lymph nodes methods are compared. Endobronchial ultrasound and endoesophageal ultrasound sampling are no longer only for champions, except for sampling the aortopulmonary lymph nodes. Remember that these staging modalities can be complementary and not mutually exclusive. Please use the modality that you are most comfortable with in your institution. And remember that thoracoscopic staging for selected patients with left upper lobe lesions is underused and often an excellent modality for assessing the T status of tumors. I will end with a patient scenario. This is a 74-year-old former smoker with an incidental 5 centimeter right lower lobe lesion found during evaluation of persistent cough. The CT images show no evidence of enlarged paratracheal or subcarinal lymph nodes, and there were no other pulmonary findings. PET scan depicted here showed intense FDG uptake in the right lower lobe lesion. There was no FDG uptake in the mediastinal or higher lymph nodes. Of note, this patient had cervical fusion of vertebra C4 through C7. How would you confirm a diagnosis? Is invasive mediastinal staging indicated? What modality would you use? And is there a role for diagnostic pulmonary resection with intraoperative lymph node sampling? I'll give you my answers for some of these. A diagnosis in this particular lesion would be difficult given its proximity to the diaphragm, and since it has a high suspicion of lung cancer, I would use diagnostic pulmonary resection with intraoperative lymph node sampling. I do think, despite negative PET in the mediastinum, this rather large lesion would deserve invasive mediastinal staging. Given her cervical fusion, endobronchial ultrasound would probably be the modality of choice where one might struggle with mediastinoscopy. Of note, this particular patient had mediastinal lymph node staging which were intraoperatively deemed negative. However, after pulmonary resection, the subcarinal lymph node was positive for disease, thus incidental N2. Thank you for your attention.
Thank you, Dr. Lanuti. The next to present is Dr. Moishe Liberman.
This is the portion on endoscopic mediastinal lymph node staging. The outline of this portion of the talk will be on the role of EBUS in lung cancer staging, the role of EUS in lung cancer staging, the use of EBUS and EUS versus traditional mediastinal lymph node staging, and then some cases. As all of you know, mediastinal lymph node anatomy surrounds the tracheobronchial tree and esophagus. These nodes in the N2 and N3 location occur within the mediastinal envelope, and N1 lymph nodes occur within the pleural envelope on the ipsilateral side of the lung tumor. Minimally invasive mediastinal staging can be performed using endobronchial ultrasound, or EBUS, or endoscopic ultrasound, EUS. Endobronchial ultrasound is used to biopsy lymph nodes around the trachea and bronchi as the scope is passed through the patient's mouth or nose into the airway. Here you see a biopsy of a station 4R right lower paratracheal lymph node under real-time EBUS guidance. EUS is able to biopsy lymph nodes which surround the esophagus. These can occur within the mediastinum or in the upper abdomen through the stomach, including bilateral adrenal glands, liver metastases, and lymph nodes in the celiac or gastrohepatic ligaments. Currently, multiple tests are used in the diagnosis and staging of lung cancer and mediastinal diseases. The majority of these tests are non-invasive, however there are invasive tests as well. Testing with invasive, minimally invasive, or non-invasive tests can prevent surgery and resection in patients with advanced benign or medically treated diseases. And the ideal test includes a test which has the ability to give a tissue diagnosis, has a high accuracy in staging, a low procedure-related morbidity, and low cost. Minimally invasive endoscopic and mediastinal staging procedures are very convenient. They can be done as an outpatient procedure. They are quite fast to perform. There is no scar or general anesthesia requirement, as most procedures are done under local and sedation. Multiple stations can be sampled within the mediastinum and upper abdomen. Aspirin is safe. These provide a real-time imaging. The machines are portable and can be done in different locations throughout the hospital and even in the intensive care unit. There is no radiation exposure to the healthcare worker or to the patient. And these are quite cost efficient, safe, and most importantly give tissue as opposed to CT and PET scan to correctly diagnose a mediastinal lymph node disease. When tailoring your diagnostic technique to the anatomy in question, obviously lymph nodes that surround the airway are capable to be biopsied by EBUS, and lymph nodes in the mediastinum surrounding the esophagus are able to be biopsied using EUS. As you can see in this slide, endobronchial ultrasound is useful in biopsying 2R, 2L, 4R, 4L, 10R, 11R, 12R, 10L, 11L, 12L, and lymph node number 7. Endoscopic ultrasound is capable of biopsying lymph nodes in the station 2R, 2L, 4L, and 4R if the lymph node is large enough to be seen as it is anterior to the trachea, 7, 8, 9R, 9L, adrenal glands bilaterally, left lobe of the liver, and celiac and gastrohepatic ligament lymph nodes. Different techniques have the ability to diagnose lymph nodes within different portions of the mediastinum, and this slide is quite confusing. However, compares mediastinotomy, VATS, mediastinoscopy, EUS, and EBUS to show which lymph nodes are capable to be biopsied with each technique. Mediastinal lymph node access. This is a preference card in our center. The highest mediastinal lymph nodes, very rarely seen in lung cancer, more common in head and neck tumors, are easily able to be biopsied using EBUS. Right upper paratracheal and left upper paratracheal lymph nodes are easily biopsied by EBUS. However, in the awake patient, EUS is much more comfortable for the left number 2 lymph node period. In the prevascular location, station 3A, EBUS is possible to be used to biopsy these lymph nodes, however difficult, and in the retrotracheal area, EUS is our preference. However, these nodes are also biopsyable by EBUS. In the lower paratracheal area, EBUS on the right is much easier, and EUS for the left side is much easier, and those are our preferences. At the station 5 location, EUS is preferred, and station 6 location, para-aortic lymph nodes are now able to be biopsied using EUS. However, this is a complex procedure and should be performed by experienced EUS operators. This is an image of how this can be done, and the technique is above the scope of this course, but can be viewed in the literature, and the references provided. In the station 7 location, EBUS and EUS are quite capable. Paraesophageal and pulmonary ligament 8 and 9 on the right and the left are both biopsyable by EUS and not by EBUS. And intrapulmonary lymph nodes, hilar, interlobar, and more segmental lymph nodes are biopsyable only by EBUS. However, the left hilar 10L lymph node is sometimes able to be biopsied using EUS. Again, lymph nodes within the abdomen are only able to be biopsied using EUS. This slide demonstrates a study looking at 503 patients who had mediastinal lymph adenopathy. These nodes were all large. There was 572 lymph nodes which were punctured, and 94% had their diagnosis made using EBUS alone. The mean diameter was 1.6 centimeters. The sensitivity of EBUS for mediastinal adenopathy in patients with enlarged lymph nodes was 94%, with 100% specificity and positive predictive values. What about EBUS, TBNA, and a CT-negative mediastinum, or lymph nodes less than 1 centimeter short axis on CT scan or PET negative? This study looked at 100 patients with lymph nodes less than a centimeter. All patients then underwent surgical staging, and of 119 lymph node sampling, malignancy was detected in 19 and only missed in 2 of these patients, giving a sensitivity of 92% with a negative predictive value of 96%. Published results for EBUS range in sensitivities between 85 and 100% depending on the pretest probability and the CT and PET scan size and positivity of the lymph nodes. Again, the smaller your lymph nodes, the lower your sensitivity and the harder the procedure is. EUS used for upstaging in lung cancer patients, 44 patients in this study with resectable tumors based on CT scan. EUS was able to change the management in 18% or 8 of the patients, and patients were upstaged either to stage 4, 3A or 3B, or 2A moving to 3A. And this is quite significant as we don't want to operate on patients who have unresectable lung cancer. EUS FNA led to the avoidance of thoracotomy in 13.6% of patients with CT findings of a resectable tumor in this study. What about combining EBUS with EUS? In the study by Hirth, 2005, 160 patients with enlarged mediastinal lymph nodes, 85% success with EBUS, 78% with EUS, and the combination of EBUS and EUS allowed for a 97% success rate in diagnosing enlarged mediastinal lymph nodes. Again, all of these patients had mediastinal lymphadenopathy. In the study by Villman, looking at 33 patients, again with mediastinal adenopathy, 119 lymph nodes sampled, half by EBUS, half by EUS. There were 11 additional positive nodes by EBUS over EUS and 12 additional positive nodes by EUS over EBUS. When you combine EBUS and EUS, you're able to achieve 100% accuracy in mediastinal lymphadenopathy. Wallace looked at minimally invasive endoscopic staging of suspected lung cancer using TBNA or transbronchial needle aspiration, EBUS and EUS, or as a combined procedure, 138 patients. And you can see here that EBUS alone gives you around a 69% sensitivity. EUS also gives you 69% sensitivity. But in the last line, you can see that EUS plus EBUS gives you a 93% sensitivity and a 97% negative predictive value for lung cancer staging. Cebulski looked at 120 patients using EBUS and EUS and performed transcervical endoscopic mediastinal lymphadenectomy in all negative cases of EBUS and EUS. And you can see that EBUS had a sensitivity of 46%, EUS had a sensitivity of 50%, and the combined procedure using EBUS and EUS had a 76% sensitivity. What about morbidity? Mediastinoscopy, as we all know, has very rare complications. However, when these complications occur, they can be devastating and even fatal. EBUS is quite safe, very few complications reported in the literature. However, as we all know, complications and morbidity are not the most interesting and are often underreported. This is a short video of a left mainstem bronchial tear performed in our center. Patient coughed when the needle was out in the left mainstem bronchus with a tear through the left main bronchus. This is a devastating complication. Luckily, the lymph node was negative, and the patient was operated that same day with bronchial repair and right upper lobectomy for finally a T2N0 non-small cell lung cancer with no sequelae. What about the cost? Mediastinoscopy overall hospital costs are between $2,100 and $1,300. The average cost in most North American centers for EUS or EBUS is around $2,000 per patient. If you combine the two procedures, the cost is around $3,000 as opposed to $4,000 due to the cost of medications and the time as well as healthcare worker associated costs. Pulmonary resection has a cost of around $22,000, and obviously operating on patients with N2 or N3 disease without proper preoperative staging is a very costly thing to the system. So if we can avoid operating on patients with mediastinal lymph node positivity, we can save that major hospital cost and allow the patients to benefit from chemo and radiotherapy as opposed to a surgical treatment. The study we recently completed looking at minimally invasive strategies for lung cancer staging in patients with potentially operable non-small cell lung cancer is about to be published. The study design looked at a prospective comparison of diagnostic test findings on a consecutive case series of patients. Each patient served as his or her own control, so all patients underwent EBUS, then EUS, and then mediastinoscopy. And patients with lymph node positivity on CT or PET in the 5 or 6 location then underwent either anterior mediastinotomy or the Chamberlain procedure or a left VATS procedure. And this was based on surgeon preference. A total of 166 patients were recruited. Here you see the methodology. All patients EBUS, EUS, and MED, plus or minus VATS and anterior mediastinotomy selectively. Over a 30-month period, 166 patients were enrolled. The mean number of lymph node stations biopsied are shown here, and the prevalence of N2, N3 disease in this sample was 32%. What about comparing endosonography to mediastinal staging, or the gold standard being mediastinoscopy plus or minus VATS or mediastinotomy? You can see that the sensitivity of EBUS was 72%. Sensitivity of EUS was 62%, and the sensitivity of a combined EBUS and EUS procedure was 91% with a 96% negative predictive value. When you compare mediastinal staging versus surgery for those patients that went on to resection because they were N1 or N0, 114 patients underwent either VATS lobectomy or thoracotomy plus lung resection. The negative predictive value of EBUS was 90%, EUS was 90%, the combined EBUS-EUS procedure was 92%, and standard surgical mediastinal staging had a negative predictive value of 89%. EBUS and EUS in this study diagnosed N2, N3, or M1 disease in an additional 24 patients in whom surgical mediastinal staging was negative. This prevented thoracotomy or thoracoscopy in an additional 14% of patients who would not have benefited from surgical treatment for their lung cancer, showing that EBUS and EUS is probably better than the gold standard and should probably become the new gold standard in mediastinal staging for lung cancer. In our practice, you can see here over the years we opened our EBUS and EUS center in 2009, and in 100% of cases on the y-axis you can see in yellow mediastinoscopy, in blue anterior mediastinotomy, and EBUS plus EUS in orange. And while the majority of procedures were being done prior to 2009 using standard surgical techniques, over the years up until last year, the rates of EBUS and EUS or endosonography have increased greatly, and the percentages of standard mediastinal staging have decreased. In fact, in 2013, which is not shown here, less than 1% of mediastinal staging for lung cancer was done using traditional surgical techniques. More interestingly, and I think more importantly, the volume of mediastinal staging has increased dramatically in our center due to these safe, quick, and cost-efficient procedures. As you can see, we are now performing in 2012 527 EBUS and EUS procedures, and in 2013, which is not shown here, we performed over 650 EBUS and EUS procedures, which have almost completely replaced cervical mediastinoscopy and anterior mediastinotomy. This is a case of EUS staging and in lung cancer. You can see this patient has a right upper lobe PET avid lesion with bronchopneumonia surrounding the lesion. The video plays now. We'll start in the abdomen. The liver is shown here. We're assessing for liver metastasis. There's the stomach folds. We're looking at the spleen. Looking around for any nodes within the splenic hilum or in the gastrosplenic ligament. Here's the left kidney. We're going to pull back, look between the kidney and the spleen to find the left adrenal gland. You can see it looks quite normal. This adrenal gland, as most normal adrenal glands, looks somewhat like a dove or a bird, and there's no nodule within it or hanging off of it. You can imagine that that would be quite easy to biopsy using an EUS scope should there be a metastasis in this patient. We'll continue on now. The IVC is shown clearly within the liver. And we're now looking at the celiac axis. You can see flow within the celiac axis, and there's little lymph nodes around the celiac artery which are echographically benign. We've now pulled into the chest cavity. You can see there's the left atrium. The inferior and superior pulmonary veins are clearly seen. And we're going to look for some lymph nodes above the atrium. Here's the thoracic aorta, and we've turned to the aortopulmonary window. You can see that the 4L lymph node occurring just under the aortic arch is shown there, and lymph nodes distal to the ligamentum arteriosum are station 5, which are clearly seen also on EUS. However, this patient didn't have any. We're going to slowly come back and look again above the atrium. This lymph node actually occurs right above the superior pulmonary vein on the left, and that's a level 7 lymph node. We went down towards the right, and just sitting behind the atrium, just below the superior pulmonary vein on the right side, you can see 3 little 8R lymph nodes, and those are easily biopsiable by EUS. Here again is the station 7, just above the vein, sitting below the carina. We're going to come back here. We're looking over on the right side. There's a bunch of lymph nodes. We're looking just above the azygous vein, and these are 4R lymph nodes, which, when they're large enough, as in this case, are easily seen on EUS, and you have to be sure that you're above the azygous vein to not misclassify a 10R into a 4R. Doppler shows the azygous vein, and we know we're above it, therefore for our lower paratracheal. We're looking within the lung in the right upper lobe here. We can see the lesion. We can measure it out. And now we're just above the lesion, looking at the 2R or right upper paratracheal lymph nodes, also easily biopsyable on EUS. Here's a fine needle aspiration biopsy of the 8R lymph node. And here's a fine needle aspiration biopsy of the station 7 lymph node. The patient is awake under fentanyl and midazolam sedation with topicalization of the upper airway. We're biopsying the 4R lymph node now in the right paratracheal area. Again, you can notice the azygous vein just to the left of where we're biopsying. We can actually do 2 or 3 lymph nodes at the same time using the EUS scope. And now we're going to do a lung biopsy for tissue diagnosis and markers through the esophagus, which we have performed over 30 times in our center without any incidence of pneumothorax or tract seeding. And this is quite helpful, especially for tumors that are behind the heart or in front of the spine, which are not biopsyable by other means. And here's the 2R lymph node again. And we'll look at that, and then we'll biopsy the 2R lymph node. And you can see just beneath there is the right common carotid artery. The next patient has rheumatoid arthritis with severe cervical spine instability and had a subcarinal lymph node which was moderately suspect with short axis of 1.2 millimeters on CT scan. The patient had left adrenal gland, clearly seen here on CT scan, and a small nodule in the adrenal gland just above. The patient had an SUV max of 8.3 of that adrenal lesion and was sent for standard mediastinoscopy to a thoracic surgeon. Because of rheumatoid arthritis and cervical instability, the patient was not a good candidate for mediastinoscopy and was sent for EBUS-US procedure. You can see here we're in the abdomen in the video looking at the left adrenal gland, which looks somewhat abnormal. There is a little bit of thickness to the body of the adrenal gland, and you'll see we'll pass a needle out right into the adrenal gland, into that nodule, and biopsy it. That adrenal gland did come back as adenocarcinoma. The patient was also positive in the station 7 position, and so therefore had a T1, N2, M1 stage 4 non-small cell lung cancer. Next patient had a Pancoast tumor T3N2 based on CT and PET. It was a 62-year-old female, healthy, a right-sided Pancoast tumor. The CT and the CT PET were both negative for any mediastinal lymphadenopathy or for any lymph nodes within the mediastinum or extra pulmonary lesions. The patient was enrolled in the trial looking at mediastinoscopy versus EBUS and EUS at our center. And patient had a mediastinoscopy showing 4R, 4L, and 7 lymph nodes all being negative. Station 7, 4R, and 2R were all negative on EUS, and EBUS diagnosed station 7 and 4L to be negative. The patient had a 4R positive, showing a few adenocarcinoma cells within the 4R lymph node, and the patient then underwent neoadjuvant chemoradiation therapy for the Pancoast tumor, which included radiation to the mediastinal bed because of the known N2 positivity. The patient then underwent a repeat mediastinal staging using EBUS and EUS, and the 4R lymph node was sterilized. And the patient then underwent a Pancoast resection with a negative complete mediastinal lymphadenectomy, which showed negative lymph nodes. This patient had endobronchial papillomatosis and underwent on a weekend an emergency right lower lobe, right middle lobe bilobectomy for hemoptysis. There was no pathology done during the case, as this was thought to be a benign papillomatosis, and the patient had been followed for 6 or 7 years prior with multiple bronchoscopies for this papillomatosis. Interestingly, about a week later, the final pathology came back and squamous cell carcinoma was found within the pathological specimen. Patient then underwent PET CT scan, and 8R lymph node and the number 7 lymph node were both PET avid, and the question was what to do for this patient and what was the true stage of her lesion. The patient then underwent an EBUS-EUS procedure for and biopsies of the 4R, 4L, 7, and 8R lymph node were all done, which were all negative. So final pathological staging was a T1N0 as opposed to a T1N2, and the patient did not receive adjuvant chemo or radiation therapy. Thank you very much.